In Chapter 16, we'll be going over the knee and related structures. The knee joint itself is a hinge joint with a rotational component. So that means it hinges back and forth like a door, but there's also some rotation that occurs at the actual knee joint. As far as the knee goes, its stability is mostly due to ligaments, the joint capsule, and the muscles surrounding the joint. So the actual structure of the knee joint, the bony structure, doesn't really give it much stability. The knee is designed for stability with weight bearing and mobility and locomotion. So the knee doesn't really twist really all that well while you're standing still necessarily, versus when you're moving, like walking and running, the knee will twist more easily. As far as the bony anatomy of the knee, the bottom half of the knee is made up of the tibia. So this part of the joint is the tibia. We call it the tibial plateau. Then technically the fibula is not actually a part of the proper knee joint, but it is an attachment site for the LCL, the lateral collateral ligament. So we do consider that to be a part of the knee as well. So the fibula, the smaller leg bone, is also part of the knee. The femur is the top part of the knee joint. So this is the bottom of the femur that articulates with the tibial plateau to make the true knee joint. And then we also have the patella or kneecap. So the patella itself is not a part of the true knee joint, but the patella resting on the femur makes up what we know as the patellofemoral joint. So there's actually a couple of joints going on in the knee area. There's the proximal tibiofibular joint here, the true knee joint right here, and the patellofemoral joint underneath the patella. As far as the soft tissues of the knee joint, like the ligaments and cartilage, we have our big four ligaments. So we have the MCL, which stands for medial collateral ligament right here, which is on the medial side or inside of the knee right here, on the true knee joint. We have the LCL, which stands for lateral collateral ligament, which is here on the lateral side of the knee, or the pinky toe side. Then deep inside we have the ACL and the PCL. So you can touch the medial collateral ligament and you can touch the lateral collateral ligament, but you cannot touch the ACL and the PCL. They're deep inside. So ACL stands for anterior cruciate ligament, and that's here in the front part of the cruciate ligaments. And then PCL stands for posterior cruciate ligament. So crux means like a cross. So these cruciate ligaments cross each other. So the PCL runs behind the ACL right here. So this is the ACL in front. This is the PCL here in the back. So technically the PCL isn't necessarily all the way in the back of the knee, but it is behind the ACL. So all of these ligaments have C in the name, but the C's stand for different things. So those more superficial ligaments that are on the medial and lateral side of the knee, the C's stand for collateral. So collateral is outside the knee joint. The collateral damage is outside the intended target. So collateral ligaments are outside the knee joint. The cruciate ligaments cross in the middle of the knee joint. Those are our main ligaments in the knee. The menisci in the knee, singular is meniscus, add padding and stability. So this is the big toe side, the medial meniscus is right in here. So the medial meniscus is slightly different shape than the lateral meniscus, so we can usually actually tell the difference if we're looking at it in a picture. But the lateral meniscus is going to be on the pinky toe side, right here. So those menisci both serve to deepen the joint, add some more stability to the knee proper, and then also add some cushion for landing purposes and shock absorption. As far as the anatomy, the muscles and tendons of the knee, we have our 4 quad muscles here in the front of the knee. So quad muscles are in the front and they're very strong. The quad muscles are knee extensors, so they straighten the leg, and the rectus femoris also crosses the knee and hip. So the rectus femoris in the very front right here can also flex the hip. That's our sacral muscle. It helps to straighten the leg and flex the hip. The vastus lateralis is here on the outside, and the vastus medialis is here on the medial side or big toe side. The vastus intermedius is deep underneath this rectus femoris. So we have 3 of those, the vastus muscles, and then the rectus femoris sits on top. The vastus medialis muscle has these very important fibers here called the vastus medialis oblique fibers. Those are very important for controlling the movement of the patella and adding stability to the knee. As far as the hamstrings go, the hamstrings are in the back of the leg or on the posterior side of the leg. And these muscles are not meant to be quite as strong as the quad muscles. Ideally, they're only 60 to 75% of the quad strength as far as hamstring strength. If the hamstrings are too dominant, that can cause issues as far as biomechanics. The hamstrings are a knee flexor, so they will bend the knee. You can see they cross the knee joint here on either side, so they can bend the knee. And they also extend the hip because they come up and attach to the hip up here. Our 3 hamstrings, so there are 3 letters in ham. We have 3 hamstrings, are the bicep femoris, which is on the medial side, or I'm sorry, the lateral side or pinky toe side of the leg, so kind of on this side. We have 2 heads of the bicep femoris, a long head and a short head. So bi means 2, and that will help to flex the knee and slightly rotate it outwards. And then on the medial side or big toe side of the leg, we have the semitendinosus, which is right here, and the semimembranosus, which is deeper inside to the semitendinosus. It's kind of coming through here-ish. Sometimes we call these the semi-twins because they run a very similar pathway, and they do basically, they do the same job. They slightly internally rotate the foot, or internally rotate the knee, and bend the knee. You can tell them apart because the semitendinosus feels very ropey and tendony. So if you were to pull your toe or pull your heel back towards you and try to palpate your tendons on the medial side of the back of your knee, you can really feel that tendon popping up in the tendinosus. And then the membranosus is flatter, so they feel a little different. You can actually tell them apart a bit that way. As far as important tendons in the knee, we have our quad tendon, which is above the patella here. We have our patellar tendon, which is below the patella here. Sometimes people call this a patellar ligament, but technically the tendinous fibers from the quads run through the quad tendon, and you can see here they don't really get disrupted as they cover the patella, so they're pretty much continuous. So a ligament attaches bone to bone only, and tendons attach muscle to muscle or muscle to bone. So I do think that it is more accurate to be calling it the patellar tendon and the patellar ligament. We also have the IT band, which is not necessarily a true ligament. It's right here. It runs down the side of the leg, and it does serve as a tendinous type attachment for two of the muscles that come from the hip, the TFL, which is a hip flexor, and the gluteus maximus, which comes around from the back side of the hip. But the IT band does attach at the knee, and it often becomes irritated at the knee. So we also consider it a part of the knee. As far as knee injury prevention, our prevention is approximately similar to the ankle. So we're going to be doing stretching, strengthening, and balance. We do have some very specific ACL prevention programs that are out there. The first was developed at UCLA for their soccer team, and it's called the PEP program, which stands for Performance Enhancement Injury Prevention. And it's actually good for any lower extremity type of injuries as far as injury prevention. But they specifically did a research study on how it affected ACL injuries, and it did reduce their incidence of ACL injuries when it was implemented. Basically, with the PEP program or any program that is similar, the person's going to do, it's usually integrated as a part of the regular warm-up. So it's slightly longer than a regular soccer warm-up, but only by about 5 minutes. So the individuals will do a warm-up, like a jog of some sort, some stretching, strengthening, balance training. They'll practice landing strategies. So like as far as the individual down here in this lower picture, doing the hopping and then practicing landing. Plyometric training, so again, the hopping, and single leg performance, so single leg balance. Generally speaking, the original PEP program did use static stretching for their stretching, but generally speaking, we would want to be using more dynamic stretching nowadays as an update to that. The strengthening also would be focusing on quads and hamstrings and gluteus muscles primarily. We could use this in rehab possibly, or in preventive training. Like in a soccer warm-up. I had a lot of ACL and knee injuries on the Ultimate Frisbee team over the course of about my first 2 years at UCSD. So I actually did ask them to use a modified PEP type warm-up. I don't know how consistent they were with that, but we did have some reduction in ACL injuries after that. So I'm not sure if that was coincidental or if they actually did keep some of those strategies as a part of their warm-up. But they can be very helpful. As far as rehab goes, we pretty much do a lot of these things in rehab anyways, but really working on the landing strategies and the plyometric training and single leg performance is not something that's always used in every rehab setting, so that is pretty important. Other prevention strategies that are specific to knee injuries would be choosing a proper shoe type. So if we're talking about athletes who wear cleats, shoes with shorter cleats are preferential as far as preventing knee injuries because they don't allow the foot to become fixed, but they still allow control with running and cutting. So if somebody's wearing longer cleats and they go to cut, if their foot doesn't move at all, then their knee will take up a lot of that force, and it's more likely to cause them to have an ACL or meniscus tear when they start to rotate away from their original direction. Another type of prevention that's common is either using a functional or prophylactic knee brace. So this would be an example of a lineman's brace. That's a common brace that maybe high school linemen might wear that would help keep them from twisting their knee. Interestingly, on the professional teams, their knee braces that the linemen wear actually really look very similar to a regular ACL brace. So that somebody might wear post-operatively. So these are things that people take pretty seriously, especially in the professional level, because they could help prevent and reduce the severity of knee injuries. Sometimes there's just so much force that the person's going to have a knee injury anyways, but if we could reduce some of that severity, that would be great. If somebody does have an unstable knee, like maybe they've had a previous ACL tear or they have a known meniscus tear that they're not going to have an operation on, then these kind of braces can provide some support. However, and then it can also control a low level of rotational and tibial forces and tibial translation. So if somebody has had an ACL tear, a lot of times their doctor will prescribe them a brace to try to control some of those forces that could cause them to become re-injured. However, they haven't been proven to necessarily be all that helpful for people who get hamstring grafts versus patellar tendon grafts. And, I spent 6 years working rugby and rehabbing people with ACL injuries that were never allowed to wear a brace. They might be able to wear a little soft-sided brace that wouldn't really control any particular motions. But in rugby, you can't wear hard plastic. It's not considered safe for the other players. So, for me, I've spent years teaching people how to control these forces with their muscles more. So I think braces can be helpful. I am not a huge proponent of braces, but I'm not against them either. Starting with assessment for knee injuries, we're going to take a history, and our history for an acute injury is going to be a little bit different than our history for a chronic injury. Remembering that the information here is provided only for informational purposes and to help with triaging an injury. So for an acute injury, we want to know what their mechanism is. What position was your body in? The forces on the knee are very different if somebody is laying on their back and somebody twists their knee versus if that same athlete is running, they plant and cut. Those forces are very different on the knee. It would be very difficult for somebody to tear their ACL by another person torquing their knee. Whereas with their own body weight, when they're cutting or they're planting and cutting and twisting, it's very easy to tear the ACL. So it is very important what position their body was in. I want to ask them, did their knee collapse or give out on them? So if that's the case, it could be an ACL or an MCL or possibly a meniscus injury. Did you hear or feel anything like a pop or a snap? A pop could mean meniscus or ACL, but sometimes your patella can actually make popping or cracking or snapping type feelings as well. So just because somebody felt a pop doesn't necessarily mean that they've caused a lot of damage within their knee, although it's not a great sign. Could you move your knee immediately after injury, or was it locked? If they felt like they physically could not move their knee, that means it was locked. If they say, I didn't want to bend my knee because it hurt, that's different. There's a difference between not being able to move your knee and not wanting to move your knee. If the knee was actually locked and they weren't able to bend or straighten it all the way, like physically they were unable to do that, then it's possible that they have a meniscus tear that's actually sticking up and preventing the movement of the actual knee. For an acute injury, did swelling occur? If so, where was it? That's helpful. Where was the pain? And then we'll ask them on the scale of 1 to 10, how bad was your pain at the time of injury? As far as an assessment for recurrent or chronic injuries, our history is going to be different. So we'll ask, what's your major complaint? Do you have pain, swelling, or stiffness? Pain on the scale of 1 to 10. How bad is it? How bad is your pain right now? How bad is it when you do things that irritate it? When did you first notice the condition? So that would be, was it a week ago, 2 weeks ago? What were you doing when you first noticed the condition? Were you running, walking, going up or down stairs? Had you just finished watching a movie and your knee started hurting? Is there recurrent swelling? So does it swell and then go back to normal and then swell again? Does the knee lock, catch, grind, or grate? Does it ever feel like it's giving away or giving out? Do they have pain with ascending or descending stairs? Most people will have more pain with going downstairs than going upstairs. So ascending stairs or going upstairs is usually less painful than descending stairs, but everybody's a little different. Most of the time that's because when you go downstairs, it requires a lot more control of your movement and your body weight. The other reason is that as you go downstairs, if you guys ever try this, well, pay attention to how your knees go. Usually your knee goes much farther past your toe when you're going downstairs than when you're going upstairs. As the knee goes farther past the toe, the amount of force on the front of the knee or the anterior portion of the knee goes up quite a bit. What past treatments have you undergone? And also, did they help? Or did they make it better, worse, or the same? That would be helpful information. Next, we would do as a part of our assessment, we would do an observation. So we'd like to try to watch the person walking. If we didn't see them walking already, we may ask them to get up off the table and walk if they're able. We'd like to look at them in a half squatted position. So if we look at them in a squatted position, are their knees more like this on decent railroad tracks, or did they go knock-kneed? If they go knock-kneed, well, there's at least one thing we know we can fix. So we have something to work on there. If we can watch them going up and down stairs, that might be helpful. We don't do that very often, but it's not a bad idea. We're going to look for any swelling or ecchymosis. So this is swelling. This is not a deformity. It's a lot of swelling, but it's not an, oh damn, your knee shouldn't be facing that direction either. Ecchymosis, again, would be discoloration. And then we also want to do an assessment of muscle symmetry and atrophy. So if we look at the person in this far picture on the right, one of their quads is significantly bigger than the other. So the VMO right here, that's a nice VMO. If we look at their other side, this is a little tiny guy comparatively. It's really more normal than the other side, but so most likely what's occurred here is this person's probably had an ACL surgery and their VMO atrophied as a part of that. And really, even if they've rehabbed this could be a year later. And this right leg could actually be stronger with a single leg press. They could hop higher, they could do all kinds of stuff better on the right leg. And you could possibly still see that amount of atrophy. It's hard to get back to this really hypertrophied state once you've had a surgery. So we're going to want to assess that. If it's after a surgery, we'll want to try to build that up as much as we can. Sometimes people are just different too. For cyclists and triathletes, they're probably going to have one leg that's, I call it their steroid leg. So one of their legs is going to be bigger than the other because with cycling, you tend to keep one leg clipped in to the pedal, and that's your power leg as you start off from a dead stop. So that leg usually becomes more hypertrophied, although it's usually not going to be as noticeable as in that picture. And we'll see this especially in the quads, but for jumpers too, we might see it in the hamstrings possibly. And we might also see their weaker leg being more likely to get injured. So that especially like a pole vaulter or a high jumper. We're going to want to look at their level of function. Are they walking with a limp? Are they walking abnormally in some fashion? So maybe their foot doesn't clear the ground normally, or maybe they swing their leg out to the side when they're walking. Maybe they kick their foot out to the side when they run. Those would all be things that, again, would be something that we could fix. It may or may not be causing their pain, but if we think it might be contributing, then we can go ahead and fix that. And lastly, can the person bear full weight? So if they can't bear full weight on the leg, we're not going to see them limping because they're just not going to put weight on their leg. For our next area of assessment, we are going to be doing palpation on the knee. So for palpation, ideally the athlete would be sitting at the edge of the table with their knee flexed to 90 degrees, like in this picture below. If they're not able to achieve this position, then we can have them laying supine or on their back. However, it's a lot easier to see all the different parts of the knee from the seated position at the end of the table. It's much easier to find the joint line here. So this little indented area right here, that little indentation on either side of the knee, right kind of at the bottom of the patella or right below the patella, that is your joint line. And that's where we start to orient ourselves to be able to figure out where the rest of the structures are we're feeling for. We do want to assess those bony structures, checking for any bony deformity and or pain. So that would be, checking the patella, checking the tibial plateau down here, checking the femoral condyles through here, checking the head of the fibula over here. So those would be our main bony landmarks. There'll be others as well, but that's where we start. Next, we'll check the soft tissue. So we can check the MCL or medial collateral ligament over here, and then the lateral collateral ligament on the other side. We can check the tendons, so the patellar tendon and the quad tendon. So the patellar tendon would be kind of in this region. Quad tendon is going to be right above the patella. And then we can assess all those areas for pain and or tenderness. The menisci are part of the meniscus is palpable right at the joint line, kind of through here. So for going right above the tibial plateau and somebody's having pain there, it's possible it could be from the meniscus, but the majority of the meniscus is inside the knee joint and we actually won't be able to touch it. As far as special tests of the knee, we have many types of special tests for the knee, but these are our 4 most common. These are what I would be using to screen somebody's knee for the relatively worse injuries that we see. So I would want to do this on most individuals who are coming to me with an acute knee injury. These are all tests for ligaments, and what we use what's called an endpoint to determine laxity and or looseness. So endpoint means basically when does the movement that we're creating with our hands stop, and we're looking for that endpoint to be similar side to side, especially assuming that they have one knee that has not been injured in the past. If they have 2 injured knees, or if they have one knee that, say for instance, had an ACL surgery or a previous MCL injury, it would be more challenging to determine what's normal for that person. Our varus and valgus tests are shown in this picture. So this is a valgus test where we're pushing the knee into a valgus position, testing for an MCL instability. For the varus test, we're going to be pushing the opposite direction. So this is the lateral side of the knee. We're going to be pushing laterally or into a valgus or varus position for that varus test, testing the stability of the LCL. So those are for our lateral or for our collateral ligaments. We're going to test that in completely straight, which is 0 degrees, and slightly bent, which is 30 degrees. For a Lachman's test, this is testing the ACL. And again, we're testing for laxity. Does that side move more than, does the injured side move more than the uninjured side? This is one way to test it. We want to hold the thigh or the femur steady or still. And then we actually pull the tibia forward, kind of in this line, on the femur. So basically that ACL is deep inside the knee. And it's kind of crossing in the middle of the knee. So we're trying to see if we can pull on that ligament to see if we can stretch it out farther than the other side. If we can, that's an indication that there maybe has been some damage to it. The anterior drawer test is also for the ACL, but it's testing it in a slightly different position. So this is our 90-degree position. Both hands on either side on the tibia pulling towards yourself. And that if that was also positive in addition to the Lachman's test, then that would be an even greater indication that the person had an ACL injury. The anterior drawer as a clinician is slightly easier to perform. So sometimes people feel more comfortable with that test. The Lachman's test can be a little bit more challenging to perform, but it is actually more accurate than the anterior drawer test. A posterior drawer test, right here we're pushing backwards on the tibia, is for the PCL, or posterior cruciate ligament. And this would be a very positive test here, where we're getting an indentation here at the front of the tibia. Normally we have a little, you can even see in this picture a little bit of a curvature coming more out, or a flat surface in that area. There should not be an inward curvature. That would be a positive posterior drawer test. Then we also have our functional tests like we did with the ankle as far as squatting, hopping, and running. As far as injuries to the knee, an MCL or medial collateral ligament sprain is a somewhat common injury. Our mechanism here is a blow to the lateral side of the knee, creating a valgus force. So again, this is our fibula. So this is the lateral side of the knee. This is the MCL on the medial side of the knee. The person is going to be struck on the outside of the knee, causing the MCL to overstretch and possibly tear. Some signs would be positive valgus test for pain and or laxity. So if they have a complete tear, such as in this picture where they're missing a lot of substance of the MCL, they're definitely going to have a lot of opening with that valgus test. If they have a more mild or a grade 1 sprain, then they might just have pain but not actual laxity. They could have mild edema, probably primarily over the medial knee. They'll have a minimal loss of range of motion. The MCL doesn't just run straight up and down. There are fibers that kind of come forward as well. So not quite to that extreme, but in that kind of idea. So sometimes if some of the fibers that come forward are injured, the person will have some discomfort with bending their knee because it's overstretching those fibers that were injured. The person's going to have moderate to severe pain. So even a mild MCL sprain can be fairly painful. They don't feel very good. A lot of times when we're walking, we just naturally put a lot of our body weight into the medial side of the knee, so that can be very uncomfortable. Our treatment is price. The person will need a knee brace for activity, maybe not for walking around, but if they're having a lot of discomfort, they can wear one for that too. We're going to do rehabs to strengthen the quads and hamstrings and fix any mechanical issues that the person has. So if they're very knock-kneed or they go into genu valgus a lot, then we'll work on strengthening their glutes to make sure that they're not going to valgus as much. We also might address any foot mechanics that could be causing that motion, like a lot of pronation, something like that. It's very rare to need surgery on these. Most commonly, somebody would get surgery because they maybe pulled off a little piece of bone and caused an avulsion fracture down there when they injured the MCL, but that's not very common. Usually these heal on their own. The person's going to need to rest for at least 1 to 3 weeks. With a more of a moderate sprain, it's probably going to be longer, more like 6 to 8, and a more severe sprain could be even longer possibly. Lateral collateral ligament sprains happen from a blow to the medial side of the knee, so the big toe side of the knee over here. So this person was kicked in that part of their knee. These are not very common. Most of the time, we tend to be more guarded with structures that are closer to the midline of our body. We don't tend to allow people to hit us on the medial side of the knee. In this case, this particular individual, it looks like, was probably doing mixed martial arts, and he just got kicked in the knee. But that's very uncommon. Most people do not allow people to hit them from the inside of the knee. So this would be more common with mixed martial arts and possibly wrestling, where somebody grabs the leg and pulls it up into an internal rotation of the hip and causes varus force at the knee. Some signs here would be a positive varus test for pain and or laxity. So the individual in this picture would definitely have a lot of opening with their varus test. Most likely he also suffered multiple other ligament injuries, because that's a lot of motion just for a plain LCL tear. The person could have mild edema, minimal loss of range of motion. Again, moderate to severe pain. These are very uncomfortable. And our treatment here would be price, knee brace for activity, so very similar to the MCL sprain, strengthened quads, hams, and fixed mechanics. And again, there's usually no surgery with these unless it's a grade 3 or complete tear. So again, this particular individual, I'm thinking probably needed to have surgery because I think that he most likely tore multiple ligaments in his knee. In fact, he could have actually dislocated his knee. So that is not going to be a no surgery knee, but most of the time with LCL sprains, they do not require surgery. Next, we have the anterior cruciate ligament sprain. Our mechanisms here can, there could be multiple different types of mechanisms that would cause an ACL sprain. Remember that C stands for cruciate versus collateral, like the other ligaments that we've discussed already. Our mechanisms here most often is a deceleration, plant, and twist, or it could be a deceleration then cut. Anything that causes a twisting at the knee and a deceleration at the same time is going to put this ligament on the most stress. Basically what happens there is it'll force the tibia into internal or external rotation, and when you get that cutting or planting, it also causes a valgus force. Sometimes people do injure their ACL just from poor landing techniques. So they'll cause the knee to go into a valgus position with some anterior translation of the tibia. We would call that a non-contact ACL injury, although cut and a plant and a twist could also be non-contact. But those poor landing technique injuries are more common in women. Just generally speaking, these are more common in women, and there are a lot of reasons why, possibly. Different reasons could include things like changes in hormone levels throughout the month. There's possibly some link to women having a slightly different structure as far as the tibial plateau. So instead of in women, instead of the tibial plateau being totally flat like this, there's been some suggestion that possibly women could have a slightly more domed tibial plateau or curved tibial plateau, which would mean that the joint itself is not as stable. And there are other reasons too, such as from a young age, women aren't always taught to land and jump quite the same way that boys are. So there could be a lot of different reasons. Signs here could be that they felt or heard a pop or a shift, or like their knee gave out or shifted. They're going to have positive Lachman's and or anterior dwarf laxity. Usually they have severe effusion, so most of the time the knee joint itself will swell up very large, but not always. Sometimes it's mild. They're going to have a loss of range of motion, moderate pain, dysfunction, so they probably won't want to bear weight on it, but some people can. Some people can walk just fine on an ACL sprain, but they probably won't want to run on it. And feelings of giving out. I had one surgeon who actually preferred not to do surgery on somebody unless they were having those feelings of giving out, because in his mind, if the rest of the body was able to compensate enough to create the stability so that they're not feeling like it's giving out, then there was no point in correcting the ACL or replacing it. Our treatments here would be priced to control swelling, so definitely all of our price, so crutches if needed, rest, ice, ACE wrap, or knee sleeve of some sort, and elevation, because this is probably going to swell pretty big. Rehab, we're going to strengthen the quad, specifically the vastus medialis oblique, or VMO, hamstrings, probably glutes, and restore a range of motion. So we want to make sure that most surgeons, if they're going to do surgery, want the person to have full extension and full flexion prior to surgery. So restoring that range of motion actually is important, assuming that they're not going to be getting more emergent surgery. We do need an MRI to confirm. So even if I've seen the most positive Lachman's that I've ever seen in my life, like I want to take a video of it to show people, I'm not going to tell somebody that they've for sure torn their ACL. What I usually tell them is, I'm concerned that you may have torn your ACL, or the only positive test I had was for an ACL tear, but there's a reason why we do MRIs, just because I feel it with my hands, and I know I feel it with my hands, I don't see the point of freaking somebody out until they've had an MRI to really confirm how bad it is. Usually these require surgery, at least in the US. In other countries, it's not as common for people to get surgery on their ACLs. But usually these require surgery unless it's a grade 1 or a mild grade 2, if the person is going back to regular planting and cutting and running and rotational type activities. For me, I don't need any rotational activity with my knee. I would be perfectly happy living without an ACL and walking straight forward, possibly jogging a little bit straight forward, riding a bike. I don't need an ACL for those activities so much. Deceleration is another thing. I probably would like to have one for that purpose. But I know my husband, it's important to him to be able to play basketball with our son. So if he tore his ACL, even though we're pretty much the same age, he would prefer to have surgery done on it so that he could continue to do any types of planting and cutting and rotational activities that he would want to do without having any ill effects from that. So it really depends on what the person's activity level is going to be after their tear, whether or not they actually do need surgery. Next, we have the posterior cruciate ligament sprain. Our mechanism here is landing on a bent knee at 90 degrees with the foot plantar flexed. So to injure the PCL, to get enough torque to actually injure the PCL, we have to have the foot plantar flexed or pointed like in this picture to cause enough torque to force the tibia backwards to actually damage the PCL. So we're showing that force line right here, and then we're overstretching the PCL here in the middle of the knee. So again, that forces the tibia backwards, and that could cause a sprain or tearing of that PCL. Signs, they'll feel a pop in the back of the knee most likely. So instead of being kind of in the middle somewhere, sometimes it'll feel like it's behind the knee. They'll have some tenderness and some swelling in the back of the knee, on the posterior side of the knee. They might have a posterior drawer test with a positive test for laxity. Sometimes it's not positive for laxity, but I did have an athlete once who had based on his MRI, he actually had a grade 1 PCL sprain, and he had a decent amount of laxity, enough for me to notice. So I would like to disagree with the radiologist that it was a grade 1. I still thought it was a grade 2, but that was what the radiologist read from his MRI. Our treatment here is price, MRI to confirm. Rehab of grade 1 and grade 2 injuries are pretty straightforward, actually, pretty easy. Mostly you're focusing on quad strength. We really don't want the person to be doing any kind of hamstring activity, or not independent hamstring activity anyways, because we don't want them to pull that tibia backwards and stress the PCL. So the person could do squats or lunges, but they shouldn't be doing any isolated hamstring curls or even isometric hamstrings at the beginning of their rehab. Maybe not till towards the very end when that ligament's had a chance to heal. So surgical versus non-operative care, we'll still try to do rehab for even a grade 3, and surgeons will usually only consider surgery if the rehab has failed for a grade 3. So they'll give it a good 6 to 8 weeks usually before they even look at considering surgery, usually of rehab, to make sure that that person is actually not going to benefit from the rehabilitation. So another type of joint structure you can injure is the meniscus. Remember that the meniscus is cartilage in the knee that acts as a shock absorber and also helps to provide some stability to the joint. So this is our medial meniscus here, and this is our lateral meniscus here. That's showing a little tear in it in that picture. So normally people injure their menisci by doing some weight bearing with rotation. The knee could be bent or straight, but somebody is unlikely to tear their meniscus if they're not doing a closed chain activity. So if their foot is up in the air, they're probably not going to tear their meniscus. This happens when somebody is going into a deep squat, say for instance, and then goes to turn, or if somebody does a plant and twist, that could happen as well. The medial meniscus is actually more commonly torn, just because of its positioning and the way that it functions in the joint. Usually some of the ligaments in the joint actually pull the lateral meniscus out of the way when the knee is moving, whereas the medial meniscus doesn't have that function. I will say, however, that in my experience, just my personal experience, my athletes who have torn their ACLs, for whatever reason, have either torn both menisci or just the lateral meniscus, and I'm not sure why. But I think independently speaking, the medial meniscus is more commonly torn. Signs here could be popping, clicking, locking, and or giving out. We could have a mild to severe effusion, loss of range of motion, and moderate to severe pain with weight bearing and or squatting. It can be really difficult to tell the difference between a meniscus injury and an ACL tear, say for instance. The main difference there is the special test, whether or not the Lachman's is positive or negative is going to give us the most information about whether or not the person has a meniscus tear versus an ACL tear. I had an athlete once who came in January on crutches after having had knee surgery. Last I saw him, he was supposed to be going to his orthopedist to get checked out for his meniscus, possible meniscus tear. Turns out he had an ACL tear. I couldn't feel it because of the way that the meniscus tear had flapped up. It was blocking his motion with his Lachman's test. Even his surgeon didn't know until he got his MRI. He went in to see a surgeon planning on getting a reading of the meniscus tear, which the surgeon also thought was going to happen, and the surgeon told him that he had an ACL tear and needed surgery. So it was a very interesting situation. Our treatment here would be price. Rehab, we want to increase our flexibility, or increase the person's flexibility, strengthen quads and hamstrings, and fix any poor mechanics. The person will need an MRI to confirm the tear. Sometimes doctors, if they really do think it's just a meniscus tear, doctors will like us to try to do a 6-week rehab first prior to trying to do an MRI, just to save the person the time, radiation, money, all of those things that go along with getting an MRI. And then if they've failed that 6-week rehab, then we'll get an MRI just to make sure what's going on. We can usually avoid surgery if it's a small tear, but we'll need surgery for a larger tear. If it's a cleanup type of surgery where they just go in and clean up a little flap that is flipped up, then that's usually about a 4 to 8 week recovery. The fastest recovery back to full play I've ever heard of was 3 weeks. I was a University of Michigan football player who was in incredibly good shape. And that's not normal. That's going to be very unusual. But I have seen people take longer than 8 weeks as well, just for debridement or cleanup. The tear up here in the picture that we're looking at, that's not going to be a cleanup most likely, just because of where it is and the way the tear is. The doctor's probably going to try to repair that. And a meniscus repair is going to be more similar in terms of recovery time to an ACL surgery than the 4 to 8 weeks. Usually that's going to be more like 3 to 4 months for a meniscus repair. So a meniscus surgery could be very different depending on how bad the tear is. If it's a small tear, it's a quick, relatively easy surgery and rehab. If it's a larger tear and it needs to be repaired, then it's a much longer rehab. So a lot less serious than all those joint injuries, we have bursitis. We talked about bursitis a little bit already. This is a very attractive prepatellar bursitis here. That's a real swollen knee. But that's all swelling and fluid outside the joint. So that's not effusion inside the joint. That's actually edema outside the joint. I can tell because it's really not at the joint line. It's actually above the patella, right? It's prepatellar. So this is the joint line's more in here. The person doesn't really have swelling there. So the mechanism here can be acute or chronic. So a person could have landed on their knee really hard while they were coming down after catching a frisbee, say for instance. Or carpet layers commonly have bursitis as well because they have a tool that they use to push the carpet into the corners of a room, and they'll jam it with their knee. So they tend to wear knee protectors for that purpose, and also because they're crawling around the ground on their knees to help protect their knee. Prepatellar injuries most often happen from continued kneeling, like carpet laying or things like that. And infrapatellar bursitis is going to be more common from patellar tendonitis. So this right here is a prepatellar bursitis. Infrapatellar bursitis oftentimes just looks like the soft tissue under the patella, kind of through here, is swollen. And that's going to be more common with somebody who just has some tendonitis that's also irritating the bursa. Our signs here for prepatellar bursitis, we're going to have very specific swelling above the patella. For any type of bursitis, it's going to feel hot and swollen and possibly look red. And this kind of swelling feels like a water balloon. So if you jiggle it, it feels exactly like a water balloon. Our treatment here would be to eliminate the cause, so stop the irritation, do rice, and take NSAIDs or anti-inflammatories to help to decrease that inflammation. It is possible to have that fluid drained by a physician. Most physicians would prefer not to do that because they don't want to risk causing an infection. So usually a physician or a doctor would prefer not to drain an acute bursitis. Usually they'll just do it if it's chronic and it's really bothering the person. And oftentimes when they do that aspiration or draining, they'll also inject it with cortisone or something like that, just to really do some extra help as far as reducing that inflammation. Another common injury to the knee would be a tendonitis or a tendinosis. Our mechanisms here are excessive strain or stress on the tendons. So common for people who are jumping, so high jumpers, long jumpers, things like that. And that jumper's knee is considered to be more commonly in the patellar tendon through here or in the quad tendon up here. Although sometimes people will call this something different. Runner's knee is considered to be the IT band tendon, so again, kind of coming more down through here. But runners can get patellar tendonitis as well, or quad tendonitis as well. So it just kind of depends. Or jumpers could actually get IT band tendonitis. It just depends. I tend to think of these as being close cousins. Oftentimes, the mechanism that causes one could also cause the other. So it's not completely unheard of for me to see somebody who has had one type of tendonitis and then starts getting another. And I always just tell them it's because they're cousins. You haven't fixed the problem all the way. So our mechanisms here could be sudden and or repetitive extension and or flexion, usually doing those both repetitively, or landing and jumping, and that will cause some inflammation. This will be especially noticeable if the person's maybe recently changed running surfaces. So a lot of times I would see this with athletes who went from playing football, say for instance, to playing basketball. They went from running on grass to running on the hard basketball courts, especially at the high school level. The basketball courts just weren't particularly good at absorbing any force. So that was a really common cause. Our signs here would be pain and tenderness, inferior or superior to the patella or over the hamstring tendon or IT band, wherever the person had pain. And that's pain with activity. Our treatment is we want to avoid any aggravating activities for itis and strengthen the affected muscles for osis. So eccentric strengthening, so like 2 up, 1 down squats, so single leg squats. So going down just on the injured leg. So if it was the right leg that was bothering me, if I had a patellar tendonitis, I would stand on a slant board or stand with my heel on a weight plate and slowly squat down to where I could without causing too much pain. Then I put my left foot on the ground and push myself back up to the start, and then keep doing that repetitively until I was getting a slight increase in pain, and then I would stop. Again, if it's itis, we're going to do ice, rest, and NSAIDs. There's no point in icing osis. If somebody's had patellar tendonitis, quote unquote, for months, there's no point in icing it. It's not an acute inflammatory thing. Ice would only be for pain relief, but it's not an inflammatory condition at that point. Again, rest only for itis. We want to do rehab as needed. If it's somebody who just has a straight up patellar tendonitis because they just started practicing on the basketball court, then they may not need a long-term rehab. They may just need to be managing their inflammation. But if it's somebody who's had that tendinosis for a couple months, then rehab would be a good idea. If the person has patellar tendonitis, a patellar tendon strap brace can be helpful. They also sell them for IT band straps. I don't personally find those to be very comfortable, but I've seen a few runners who've worn them and seem to like them. So that's always an option. So Osgood-Schlatter's disease is our next injury we're going to discuss. This isn't really a disease. I think it's funny that it's called a disease. But basically what happens is, this is really common with kids during their teenage years. So starting anywhere really from 10 to 12 up until even possibly 20 years old, this can happen with people who are going through big growth spurt. And what happens is that the bone of the femur grows faster than the muscles of the quadriceps. So the muscles of the quadriceps start to pull on the tibial tuberosity down here, or the tibial tubercle. Those can be called, those are the same spot. So we get an inflammation at that spot. It's a result of the repeated pulling of the tendon because of the growth spurt. And the person will develop a bony callus. So eventually the inflammation gets better, but that bony callus will always stay. So as the person stops irritating that spot, like if they rest on it, or if they've changed sports or something where they're not irritating it as much, that pain will decrease as the person gets older because their muscles grow bigger, longer, and so it catches up with the femur. And so that pain will go away, but the bump will stay. So if you've had anterior knee pain in the past, and you look down at your knees and you have a big bump like this, a lot of times it's worse on one side than the other. And the other thing is like it's not going to get better if that's already been there. It's just that's how it is now. It's a callus, it's a bony callus. Again, this usually occurs during growth spurts, so common in like a 12 to 13-year-old range, all the way up through 16, but it can happen as early as 10, and it can go. I've had college age athletes who are still going through a growth spurt, and they got this. Our signs of the condition are swelling, pain with activity, and tenderness over the tibial tubercle. Conservative care for this would be to reduce the stressful activity until the bone callus occurs, which takes about 6 to 12 months. So the person will have to take a rest from their sport for a bit. After that callus has formed, then padding could be necessary just if the person's going to fall on it. So if the person was a basketball player or a volleyball player or a football player, I'd probably recommend some padding there. If the person isn't responding to just rest, then they might need to be casted, although that's probably not a preferential thing since that can really reduce range of motion in the joint. They're going to have to ice before and after activity. And they'll do rehab, probably lots of massage and stretching of the tight muscle groups, and maybe surgery to help protect that. Sometimes if the pulling is bad enough, the muscle can actually pull off a little piece of the bone that's down here. And so that's usually what the person would have surgery on, is to reattach that bone. So this is another one of the slides where we have two injuries here that I'm going to kind of compare and contrast. The reason that they're on here together is because they're somewhat similar. Their rehabs are actually almost exactly the same, but they're somewhat similar in their own ways. The main difference is that a patellar dislocation is an acute trauma and patellofemoral syndrome is a chronic condition. So if we look at these two, in this picture down here, that's showing us patellar dislocation, and that's kind of where it tends to go. So that patella there should be actually sitting right about here. So usually it'll go right next door, so it goes usually laterally, just because of the shape and structure of the patella. It's much more easily dislocated laterally. And in fact, even if somebody managed to dislocate their patella medially, it usually pops right back in. The mechanism for this is acute. Usually it's from a valgus force of the knee. So usually the knee is forced into this position and kind of torqued that way. And basically the patella stays still and the rest of the knee goes to the side. And that quad pulls the patella out of alignment. Its repetitive dislocations can cause the supporting structures to get weak, and that will cause abnormal tracking, which can cause it to be easier to dislocate and or cause patellofemoral syndrome actually. If somebody has a first-time dislocation, we'll have to leave it. We can't put it back. If somebody's repetitively dislocated, this is one of the most simple dislocations to put back. It doesn't always work, but all you have to do is straighten their leg. You straighten their leg and it pops right back in to where it's supposed to be. However, I will say that I have watched a physician that I was working with do this to somebody on the field, and his patella would not stay in. She actually had to hold his patella in, and we had to tape it to get it to stay still, to get it to stay relocated. So it doesn't always work, but that is the simple fix for this. Our signs for patellar dislocation would be pain, swelling, and decreased range of motion. Usually the person is going to feel kind of stuck in the bent position, but even if their patella goes back in, they're not going to be able to bend their knee as far. They're going to be really tight with their knee range of motion afterwards. If the patella remains dislocated, then it's going to result in a total loss of function. Even if it goes back in, the person's going to be in a lot of pain and probably won't want to walk normally. Again, for that first time dislocation, we're always going to assume there's a fracture. We do not try to reduce those or put them back into place ourselves. We're going to do price and call EMS if it's a first time dislocation especially. Following reduction or getting put back, the person is going to be immobilized for at least 4 weeks with the use of crutches. The person, in this case, will be immobilized in a straight leg immobilizer, so they won't be allowed to bend their knee except for when they're doing rehab. I will say that that is almost the only time I would ever put somebody in a straight leg brace, unless they had or in a straight leg immobilizer, unless they had a patellar fracture or something. Sometimes in the ER, people are put in a straight leg immobilizer for like an ACL injury, for a simple ACL injury, and that stuff drives me crazy because there's no need for it. Most of the time people can very comfortably and safely move their leg around, except for with the patellar dislocation, because if somebody has a patellar dislocation, then it's reduced. It's likely to come out again until the muscles get a little stronger. So it needs to be kept in a straight leg position so they don't like roll over in their sleep and dislocate it basically. Our rehab here is going to be strengthen quads, especially the vastus medialis oblique fibers, because those vastus medialis oblique fibers are these little fibers coming through here. They're going to help pull the patella back into place. So very, very important for this type of injury. Also glutes, because oftentimes these people have gotten injured going into a valgus position, so the glutes will control that valgus position, and hamstrings. So switching gears a little bit, going to our more chronic condition. For the patellofemoral syndrome, it's a chronic abnormal tracking. So we'll talk about that a little bit more down the line too, but for a chronic abnormal patellar tracking, somebody will, instead of being very, very centered in the middle of the knee with the patella, the person would just naturally kind of drift out here. That's actually not dissimilar from the position that my patella is kept in. So if I bend my knee and you guys look at my knee, my patella kind of points about 30 degrees off to the other side of the room. And that's not uncommon for a lot of women especially, but men can have it too. So that's what it's meant by abnormal tracking. It's just held in a weird position normally. And that's usually from tight structures on one side of the patella and weak structures on the other. Our signs for patellofemoral syndrome are PFS, are pain with walking, running, stairs, and or squatting, and sitting for long periods. We call that theater sign. So say for instance for me when I was younger, if I would go sit in a movie theater and forget to put my feet up, if I would keep them down on the floor, my knees would be killing me after the movie. I could barely walk because of my PFS. So anytime you're sitting for long periods, that can be uncomfortable. So now I've gotten into the habit, if I know I'm going to be sitting for a long time, I move around a lot. I bend my knees, I straighten my knees, and I just don't stay in one position. If somebody is continuing to run or play with PFS, they could definitely get recurrent swelling. They could get a feeling of grating or grinding with flexion and extension, especially repetitive flexion and extension. Treatment here would be price and NSAIDs as needed. Rehab, focusing on strengthening the quads, especially the VMO, hamstrings, and increasing flexibility, especially in the structures that could be pulling the patella laterally. And we want to avoid any aggravating activities to the extent that we can. So chondromalacia patella is our next injury we'll talk about. Chondromalacia means literally bad cartilage. So chondro is cartilage, mal is bad. So bad cartilage. Basically the cartilage on the underside of the kneecap gets screwed up. And that happens most often because of poor tracking. So it could be a lateral tracking, such as in this picture, or it could be maybe the person is carrying their patella too high. That would be another reason that could be irritated. But basically, the cartilage or the patella is digging too hard into one of the femoral condyles, or maybe even the top of the cartilaginous covering of the femur at this end of the femur, and it causes friction and wearing away of the cartilage. So a softening or deterioration of that cartilage is the definition. But this is a cool picture too of the patella because it shows you the contours of the patella. So see how this lateral portion of the patella is nice and flat? This medial portion is kind of more of an extreme angle. That is part of the reason why the patella is so easily dislocated laterally, because it slides out since that lateral portion is so straight, and then it gets stuck on that severely angled portion, and then it kind of stays out. So I like that picture. So some reasons that we could get chondromalacia would be that possible abnormal patellar tracking, usually lateral, due to genu valgum, so the knees kind of being knock-kneed. External tibial rotation, or the tibia is being rotated out. Foot pronation, or the arches falling. If the arches fall, the knees often follow. They follow into a genu valgum. Femoral anteversion, which is kind of a rotation of the femur. Patella alta, or the kneecap being carried too high. A shallow femoral groove. So if that groove that right here that the patella is meant to sit in is very shallow, then it's going to cause more friction, more rubbing, more irritation. Increased Q angle. So the Q angle is basically if somebody has very wide hips in relationship to kind of where they carry their knees is the best way to describe it. And the laxity of the quad tendon. So if the quad tendon's too relaxed, then the patella is not going to be held in a proper position. Signs here would be pain with walking, running, stairs, and squatting. So probably most commonly they're going to have pain with going downstairs or downhill with walking or running. They could have possible recurrent swelling, grating sensation with flexion and extension. This person's also going to have theater sign probably, as far as having discomfort with sitting for long periods and then standing and walking. So the chondromalacia patella and the abnormal tracking and PFS tend to kind of go together. Like I said, they're very close cousins, possibly even siblings. For conservative measures here, we're going to do price, NSAIDs, isometrics for strengthening, especially that VMO or vastus medialis oblique fibers. We want to avoid aggravating activities. So we're probably not going to have the person do squats. If we do, we'll have them do mini squats, not deep squats. And or we may just have them do wall sits instead because it's isometric and won't hurt as much. We do have some possibilities for surgery here if the person's having a lot of pain or discomfort or swelling, recurrent swelling. Basically, they could do an arthroscopic surgery where they just go in and kind of clean up the cartilage damage. Or more severely, if the person's having a lot of problems with this or patellar alignment, they can go. The doctor can go in and actually take the patellar tendon where it attaches here to the tibial tuberosity. They'll hack off that attachment and then move it next door over here, so that instead of sitting out this way, now the patella will be moved over and it will sit over here. That's a very extreme surgery, and I've only heard of even 1 or 2 people having that surgery done. It's not a common thing that doctors will do there. Last but not least, with our knee lecture, we have a patellar fracture. These are not particularly common. I only know of two or three people who've had this type of injury, actually. This is a pretty nice x-ray of the patellar fracture right through there. And that one's probably going to be from direct trauma based on how the way the fracture is. So this can happen from direct or indirect trauma. If somebody has indirect trauma, it's often from a severe pulling of a tendon. So this would be somebody maxing out on really, really, really heavy weights, say for instance for squatting, or maybe landing from a really far fall. So if somebody jumped off the roof of their house and landed, and their tendons or their muscles were trying to take up the force from that, then the tendon could possibly pull the patella apart. But so again, that's going to be forceful contraction, falling, jumping, or possibly running, I guess. Our signs here are going to be hemorrhaging and joint effusion. So this is going to be very swollen injury. Indirect fractures actually cause more damage. They can cause capsular tearing, separation of the bone fragments, and a possible quad tendon tear. So that's going to be a much more complicated fracture. With a direct fracture, there's not as much bone separation, and it's going to be probably a cleaner fracture line versus more of an explosion of the patella. Treatment here would be they would need X-ray to confirm, price splint if we suspect the fracture, refer to the doctor, and they'll probably be immobilized in a straight leg brace for 2 to 3 months. And after that, they'll probably have to be doing a lot of work on their range of motion and things like that to get all their knee range of motion back. And that is the end of our knee lecture.